Hello, and welcome to the 10-Minute Massage Podcast. My name is Troy Levine. I was in massage school. I wasn't really taught very much about the skin, and I don't think a lot of institutions or schools do teach a lot about the skin in manual therapy. We talk a little bit about the chemistry of it. We talk a little bit about the makeup of the epidermis and the dermis and the reticular layer and collagen and things like that. But the relationship between the skin and treatment is rarely focused on, and I think that's unfortunate. I also think it's a little asinine and almost backwards on therapists' part to ignore the skin or not think of it as part of our treatment. Paul Ingram once wrote me a really wonderful message where I was talking to him about the sensory system and its relationship to muscles and touch in the brain. And he said, imagine if we had a steak and you were to wrap it in saran wrap. If you were to apply pressure to the saran wrap, you would be affecting the steak underneath it. And as long as the saran wrap doesn't break, you would be changing its shape and form. But if you let it sit long enough, that steak is going to take its old form back again, and the saran wrap will just be a layer around it. Well, if we think of fascia or skin, and for me it's really the idea that skin, of that layer as that layer of saran wrap, it's important to remember that as therapists, we never touch muscle. The way therapists talk about manual therapy, I often get the impression from other therapists and students that I speak to that they describe that they're touching a muscle. And it's important to remember that we're not penetrating the skin. Very few therapies do. Yes, ultrasound does and needling does, but very few therapies penetrate the skin. Almost all manual therapy, especially hands-on therapy, and most tool therapy is done at the layer of the skin and nothing else. Yes, we are applying pressure as that image of the saran wrap, but we're still only touching skin. And most of the sensory input that is occurring in the brain and most of the positive or negative feelings that a patient experiences from tactile stimulus come through the skin. And so as therapists, ignoring the skin and not using it as one of our potential organs for treatment, it's almost like missing the ball. There's so much value in evaluating the skin, from looking to whether the skin is dry or red or veiny, whether there's an underlying condition. I'm not saying we know what the underlying condition is, but I am saying that if we evaluate the skin, we can potentially highlight certain concerns. Something that often comes to mind is a really old arthritic knee where the skin is almost reflective and glassy in its look, where it's red. It doesn't necessarily mean that treatment's going to help that. That's not what I'm saying. But it means when we look at that type of skin, you can see there's an underlying concern and there's likely discomfort with it. And so it's one of those things that the skin is often ignored, it's something in the way to get to the treatment, when in reality, the skin is where the majority of our tactile sensory system exists. And it's where we are creating possibly most of our most significant changes. Another thing to think of with that is when we're dealing with touch, when I approach my clients and I approach treatment, I often think of some of Tiffany Field's research where she talks about moderate touch and moderate pressure being one of the ones that has shown to have some of the most positive effects and well-being on clients. And when I think about what moderate pressure is and moderate touch, it's difficult to judge. They don't put a scale in those papers, and that's unfortunate. And so the way I often use it with a scale, and there are some measures that you can find where we find out what level of touch is needed to penetrate to certain depths in the body. Like we know, for example, that 3 to 10 grams of pressure is sufficient to affect the epidermis and dermis, and that up to 120 grams we've seen begins to affect pressure on the subcutaneous fascia or superficial fascia. And then we've seen that up to 450 grams can begin to affect articulations and joints and things like that. And so when we look at what moderate pressure might be, the way I try to describe it to most of my patients, most of my students, is confident touch. You're placing your hand on the body with confidence, not aggression. You're not going in super deep, not super light. You're not a creeper. You're just a confident touch. And that confident touch, when you touch the skin, it really gives the sensation of ease and relaxation to most clients. And there's a lot of benefit to that. And again, though, that confident touch comes from the skin. You are touching the skin. And that's really where your patient and your client are beginning to feel a sense of comfort. And so I think ignoring the skin is often something that therapists are guilty of doing. And we should probably change it. We should begin thinking of it as, it doesn't mean that you're not going to apply pressure. It doesn't mean that you're not doing the work you're currently doing. It means that you're approaching it slightly differently, and that will actually modify the speed of a stroke. It will modify the depth. It will modify how you offer treatment when you approach it from a different angle, and thinking of the skin as the largest sensory organ, and as the organ where maybe that's where we're trying to affect a positive change with our clientele. So it's often something that is overlooked, and I think it's something that we need to begin delving into a little bit more with research. And I try to teach a lot of that in the sensory approach to manual therapy, because it's something that has a lot of value. One of the things we look at is we get out an electronic scale in class, and then we begin palpating the electronic scale, and we try to stay within 0 to 3 grams of pressure, 0 to 10 grams, 0 to 25, 0 to 120, and then up to 450. And it's very difficult to do. I've been practicing this for about 10 years now, and it's still very difficult to do. And yet it only enhances my ability to touch a client with confidence and a sense of ease, where they feel more at ease more quickly with my touch. So it's something that I recommend practicing, and it's something I do in my classes with my students. And the other thing to think about with skin is there was a friend of mine, or someone I met, who at one of the international kinesiotaping conventions in Dusseldorf back in 2013. And he is a Swiss guy he had an interesting theory called the water balloon approach to the body. And it's just a theory, but essentially what he was saying was that imagine the skin of the body as the water balloon and the interior structures as the water. And when you squeeze a water balloon, one side becomes very compressed and the other side becomes very distended. Now that's an extreme example, but if you think of crosshatch syndrome, if you think of somebody hunched over, if you think of somebody who's injured themselves and there's inflammation taking place, like in an ACL injury or something like that, or a sprained ankle. When we think about this inflammation on the interior of the body with an acute injury, or we think about tension in the body that exists with chronic injuries, looking at what skin is compressed on one side and is the skin distended, and is that where they're getting their symptoms of discomfort? And again, it's purely theory, but it is an interesting thing to start thinking about exploring. Is the skin the reason for that discomfort and the upper back tension? Does it necessarily come from muscle tension? Does it come from fascial distortion? Do those things even exist, or is it really just in the skin? Again, theories only, but interesting theories that should make therapists question what they do. It should definitely make us question our palpation skills and our pressure, and it should make us practice those palpation skills and pressure. And I think that's something that most therapists rarely do, is they go to take continuing education courses, and they'll learn about new science and they'll learn about new techniques, but we rarely go back to our basics of basic palpation skills. And I think it's something that we should reevaluate. So I hope you enjoy, and just think about the skin a little bit more. And I would love to hear your theories about skin, and I'd love to hear more about what you guys think it can and cannot do, and how it affects positive or negative change, whether it's really the culprit behind some of these tensions that we describe as chronic pains, whether or not it's effective as a treatment organ, whether it's something that we should just completely be ignoring, whether we're off the mark thinking that the skin might be something to integrate into treatments. Thanks.
There's a time when the operation of the machine becomes so odious, makes you so sick at heart that you can't take part. You can't even passively take part. And you've got to put your bodies upon the gears and upon the wheels, upon the levers, upon all the apparatus, and you've got to make it stop. And you've got to indicate to the people who run it, to the people who own it, that unless you're free, the machine will be prevented from working at all.